Hi, my name is Katie McFadden. I am a certified nurse midwife, a registered nurse certified in neonatal intensive care, a neonatal developmental care specialist, and an advanced nurse lactation consultant. I recently resigned from my position as a staff nurse in the neonatal intensive care unit at SUNY Downstate Medical Center, which is a segregated Black state run healthcare facility where over 90% of the patients we cared for were of African descent. And while I was, during the 5 years I worked there, I was also completing my midwifery education. Um, and during midwifery school, we learned about the racial disparities in maternal health outcomes. And I thought to myself, wow, this data is recent. Some of it is based here in New York City. All of the patients I care for and interacting with are Black. I really need to pay attention to this issue and learn more about it. So, because it's directly relevant to the population that I'm caring for and working with. So I wanted to share some of the things that I've been learning over the past couple of years with Senator Warren, because my sister texted me the video yesterday of her plan for reducing maternal or racial disparities in maternal health outcomes. And I'm super excited that she's talking about it. I'm super excited that Kamala Harris is talking about it. I think it's something that every Democratic presidential candidate needs to be thinking about and talking about. But besides being excited that she's paying attention to the issue, I am concerned about her understanding of the issue, the way that she's framing it, and also I am concerned with the specifics of her plan. And I wanted to, instead of writing my sister a whole treatise, I thought I'd make a response video and kind of explain my thoughts on that. So the first thing I am concerned with is that Senator Warren framed the issue and said, for the past 25 years, the United States has been failing mothers and babies. And so that is concerning on two accounts. So the first is that I think it belies a misunderstanding of the data, because we did see an uptick in the 80s, 90s in maternal mortality. But every time we saw an uptick in maternal mortality, there had been a change in the way the data was collected. And so most of the research that discusses this phenomenon, the uptick in maternal mortality, really says it's unclear whether or not more women were dying or if we were just getting better at capturing those deaths and recording them. The second reason why she shouldn't have framed the issue as being something that's 25 years old is because she then goes on to the rest of the interview. She's talking about racial disparities in maternal health outcomes. And those have existed since we've started collecting the data. So from the 1850s, we've known that Black babies were about 2 times as likely as white babies to die before their first year. And in the 1930s, when we started collecting data on maternal mortality, Black women were 1.5 to 2 times more likely than white women to die in childbirth. So the disparities that we see today, it was never that things were equal in this, like we had slavery, then things were equal, and then things are going back to worse. The disparities are an unbroken connection between the conditions that originated most of the disparities in slavery to today. And I like that has to be at the forefront of every conversation, because if we're not thinking about the entirety of the way that white people have oppressed Black people in this country, the entirety of the way that racism has expressed itself through every stage we've been in as a nation, we're not going to understand every reason behind the increased Black maternal death rate. Uh, Harriet Washington says in the book Medical Apartheid, in the introduction, historical silence is a grave omission because trying to ameliorate African American health without understanding the pertinent history of medical care is like trying to treat a patient without eliciting a thorough medical history, a hazardous and probably futile approach. So I really think until we have some kind of comprehensive truth, reconciliation, and reparations process where we deal with the original sin, which was slavery, we're not going to be able to really deal with the whole scope of issues and with the entirety of the issues that would need to be addressed to see true health equity and true reproductive justice available to every American. So the next thing that Senator Warren said that I want to correct is she said, and the exact quote was, "The best studies that I have seen put it down to one thing: prejudice." And that is, as far as I'm concerned, that is just not true. So here I am in my office, and right here you can see my color-coded files, and this is pretty much all of the research that has been published in the past 20 years about racial disparities in infant maternal health outcomes. And I've read most of those studies, and many of them posit in the discussion section that interpersonal bias and prejudice amongst providers may be one of the mechanisms through which we see healthcare disparities, but none of them directly implicate prejudice. What I think happened is that what Elizabeth Warren heard, which is absolutely true, which is that the common factor underlying all of the disparities is racism. But racism is not prejudice. A lot of white people get that confused, but racism isn't prejudice. So what the studies show us is that there is nothing inherent to Blackness or to like the genetic makeup of people of African descent that would make them 3 to 4 times more likely to die in childbirth. And that all of the things we have been able to identify as increasing the morbidity or mortality rate have in one way or another to do with the racial discrimination against African Americans in this country. So now let's talk about the actual plan that Senator Warren proposed and the issues with that. So the plan that Warren proposed was to talk to hospitals in a language they understand, money. And so instead of paying hospitals fee for service, she proposes paying hospitals kind of a bundled package based on their outcomes, giving bonuses to hospitals that are able to improve their maternal mortality rates, and fining hospitals or financially penalizing hospitals that have poor maternal mortality rates. And the main issue with this proposal is that it is premised on the idea that hospitals all have equal access to resources, and that the hospitals that have better outcomes because the providers are less prejudiced, and that the hospitals that have worse outcomes because the providers are more prejudiced. And as somebody who has been living and working in central Brooklyn, in segregated Brooklyn, for the last 5 years, I'm just here to tell you that isn't true. That's not what's going on. And let me share with you some of the data that proves that. So the first thing to understand is that healthcare providers are not reimbursed the same for providing the same services by various health insurance companies. And the crux of that issue is that Medicaid reimburses at half the rate of private insurance companies for obstetric care. So, and it is acknowledged within Medicaid and within that system that because they reimburse at such a lower rate, it's acknowledged that if you only saw Medicaid patients, you would not be financially solvent, because within Medicaid legislation is something called the Disproportional Share Fund, which is supposed to give extra money to hospitals that care for a disproportionate amount of Medicaid patients. So if Medicaid reimbursement covered, well, if we thought it covered the full cost of care, we wouldn't think we needed to have an extra pool to go to healthcare facilities that serve a disproportionate amount of Medicaid patients. But instead, what we've done is ended up relying on a system that assumes you're going to have some mix of patients who are paying with private insurance and patients who are paying with public insurance, and that together that's going to give you enough money to run a financially solvent hospital and a financially solvent medical practice. Now the issue is when you take the government injustice of reimbursing at half the rate for an insurance that provides care or coverage for 2/3 of Black birthing people, is that when you also use the government to segregate communities and concentrate Black communities, it means you concentrate the Medicaid payer pool to the hospitals that serve those communities. So here's a map that I made that shows the ethnic layout of Brooklyn, and then the numbers are the geographic location of hospitals ranked 1 through 10, safest to most dangerous. And what you can see is that the 3 most dangerous hospitals are all located in the center of Black Brooklyn. So what makes these hospitals more dangerous? Is it that the providers at these 3 hospitals are way more racist than the providers at other hospitals? No. But when you only frame the issue of disparities in terms of interpersonal biases and prejudice, it essentially accuses the staff who work at predominantly Black healthcare facilities of being, like, the logical conclusion is they are the most racist, they are the most prejudiced. But in real life, the staff at predominantly Black serving institutions are predominantly Black themselves and are experiencing the structural racist forces of having some of the poorest working conditions in the city, some of the lowest wages in the city, some of the least opportunities for career advancement in the city of anywhere you could be working in healthcare. And so Senator Warren's proposal is kind of a double whammy, because not only is it ignoring the true cause of many of the disparities, which is the unequal distribution of resources and the government itself valuing the care provided to the majority of Black women at half the rate that private insurances value it at. But you're ignoring what providers such as myself from these institutions are telling you, which is that we don't have the money we need to provide the care that we know our patients deserve. In 2017, the New York State Nurses Association put out a report on restructuring the New York City Health and Hospital Corporation. And this report emphatic, unambiguous conclusion is that the reason why public and safety net hospitals in New York City are constantly having financial issues and running financial deficits is not because they are poorly run or inefficiently staffed, but because they are simply not reimbursed the full cost of the care that they are providing to people. So they are providing $1,000 worth of care to a patient and getting $500 back from the government. So of course they're going to be running a budget deficit. But while the true origins of public hospitals' financial difficulties should be obvious, they haven't been. And so in 2013, when SUNY Downstate had a huge budget deficit caused by the poor reimbursement for services we provide, instead of the government deciding to reimburse us appropriately, they instead forced the hospital into a process of budget restructuring, which instigated huge layoffs and hiring freezes. At the time that this was happening, our union representatives said publicly, hospitals have been able to stretch a dollar only so far, and now it's beyond the breaking point. I wouldn't call it a bailout. It's just basically the state putting money where its resources are needed to provide services to the public. What's the state to do otherwise? That's why we have government. But in the same article, and quoting the person from from SUNY, who was overseeing the restructuring process, she said, we need to be able to right size ourselves into a model that gets us a little bit more in line to where our revenues are. Hear that. In the restructuring process of the state run hospital that serves the community that had been segregated by the state, the purpose was to get the services the hospital provided to be in line with the artificially low revenues that the government was providing, and not in line with the health needs of the community. And so what has ensued since 2013 was a series of hiring freezes and layoffs, which caused constant and chronic understaffing. Both understaffing in the sense that there are often not enough doctors and nurses working on the floors to care for the number of patients that we have and the acuity of the conditions that they have, but also there are entire missing specialties within the hospital. And so if you have a health condition that would be well addressed by somebody with specialist training, you just don't get that attention. So for example, our NICU is a regional perinatal center, and as such, it's required by state regulations that we have a physical therapist or an occupational therapist on staff with neonatal expertise, and we don't, because the PT who used to work in our NICU resigned during a time of hiring freezes, and so we couldn't hire someone to replace them. And so the entire time I worked in that NICU, none of the babies were receiving physical therapy care or occupational therapy care, and that is directly related to negative health outcomes, which will follow our NICU graduates for the rest of their lives, and in some cases may have contributed to their deaths, because the specialty that PTs and OTs bring into play support overall development, and if the baby is developing better overall, they're less susceptible to developing the types of diseases and infections that end up killing NICU babies. So to go back to Senator Warren's plan to reward hospitals that are doing well and penalize hospitals that are performing poorly really only serves to exacerbate the pre-existing inequities with hospital funding that underlie why the poor performing hospitals are performing so poorly. And kind of the paradox to Senator Warren's simplistic plan is that if, looking at Brooklyn, if she's going to ding the most dangerous hospitals, well, those are already the hospitals that are dangerous because they don't have enough money, not because patients are experiencing significant amount of interpersonal racism. And they seek to reward, like, the hospitals that are doing better in Brooklyn that would be getting the bonuses are actually the hospitals where the differences in outcomes between white women and black women within that hospital are the greatest. So it may be rewarding the whiter hospitals that overall have better results because they have more resources, but that actually the lived experience of black women in those hospitals is qualitatively worse, because instead of receiving culturally congruent care with providers who are from their same community, they're receiving care from people who have internalized racism because they're at places with more white people. So I again want to commend Senator Warren for caring about the issue, for thinking about it, for incorporating it pretty early into her campaign. But I just want to challenge her to think about this more, to bring in people into the campaign in a policy advisory role that have a better understanding of this issue. And if you need a 1 minute, 2 minute stump speech on addressing racial disparities, I think as a representative of the government, you need to speak to the primary way the government participates in creating those disparities, which is by not paying healthcare providers enough to actually provide quality care to the majority of Black birthing people.